The next talk, we're going to move from the brain surgery to the eyelid surgery. And my oculoplastic partner at the university, Ali Mokhtarzadeh, is going to talk about what's new in blepharospasm surgery. So, Ali, welcome. Thanks.
All right. So, as the other speakers have said, thanks to the foundation for allowing me to come to speak. And thanks, Andy, for inviting me. So I was tasked with speaking about what's new in blepharospasm surgery. And I think the short answer is everything she just said. That's incredible.
Thank you for your talk.
Exactly. I come from a eyelid, eye socket, tear duct background, and so I'll talk to you more about eyelid surgery, which is not nearly as high-tech and three-dimensional as everything she said. That's truly amazing stuff. So, as you know, a specific cause for blepharospasm remains elusive, especially for simple eyelid surgeons. And we have lots of clinical and laboratory experience, and the general consensus is it's a multifactorial process that affects a complex circuit involving the brain with input and output, and a problem somewhere along this circuitry disrupts things and leads to abnormal modulation of the eyelid and face control muscles. So in the case of blepharospasm, as we've heard a couple times, this results in increased blinking, and like Dr. McClellan showed, sometimes it's mild and it's just a nuisance annoyance kind of thing, and then sometimes it progresses and becomes very severe and can be very disabling. And in the past, all we had for the management of blepharospasm was surgery. Now, all of that changed with the advent of botulinum toxin, which has now become the gold standard, and I think we'll hear about that a lot more coming up. But both surgeons and patients have benefited significantly from all the experience from this prior era. But with all that said, all of these treatments, all of these different ways of approaching things aim to disrupt the circuit that's leading to the abnormal movements, whether it be the tinted lenses or deep brain stimulation is interrupting this vicious cycle, or eyelid surgery. So in the era of botulinum toxin, where botulinum toxin is king in the management of blepharospasm, why would anyone decide to undergo treatment with a scalpel? And usually this is in the setting of what people refer to as quote-unquote toxin failure. So toxin failure, the botulinum toxin truly not working is exceedingly rare. The toxin almost always makes the muscle significantly weaker and should decrease the spasming by the squeezing muscles around the eyelid. The problem is sometimes the patient has other paraocular or around the eye changes that cause them to no longer respond, to have that same improvement in quality of life that they once had with the initial botulinum toxin injections. And this can be because of heavy upper eyelid skin, everyone undergoes facial aging changes, and if you're constantly squeezing your eyes, those facial aging changes will be accelerated. And I'll show you a picture that nicely demonstrates this shortly. A lot of people have dry eye problems, and Dr. Soparker is going to talk about that more, and sometimes there's procedures to help with that. Eyelids can turn in, turn out with lashes rubbing on the eye, tearing, and these are all kinds of things that we can help address. So there's no way I can address all of the procedures available to patients with blepharospasm, but by way of history, it's nice to understand the anatomy. So the facial nerve is kind of the final part of this circuitry. It's what transmits the information, the abnormal information in the case of blepharospasm, from the brain to the muscles of facial animation. And so basically it's carrying the signal from the brain, and then this is the squeezing muscle around the eye. And the pioneers in blepharospasm surgery tried to disrupt the circuitry by cutting the facial nerve. That was called a surgical neurectomy. And this works well to stop the spasms, at least initially if the nerve branches don't grow back. But the problem was these control a whole bunch of other muscles of facial animation, and so the patient would have bilateral facial palsies, or the animation muscles of the face would no longer function. And I think this is a Rick Anderson quote, who's a true pioneer in the surgical management of blepharospasm. These patients may have been happy that their spasms had stopped, but you wouldn't know it because their facial expressions couldn't show it. And this isn't a patient who underwent neurectomy. It's actually a picture from the internet of someone with bilateral facial palsy. But you get, it's not a very targeted treatment. And then in 1981, Dr. Anderson published what he referred to as the full myectomy procedure. And this involved removing as much of the squeezing muscles of the eyelid. So this is the orbicularis oculi. This is the muscle that squeezes the eyelid closed and also pulls the brow down. And then the procerus and corrugator muscles are up here, and they also pull the brow down. And he would make 3 incisions along one above the eyebrow, one above in the eyelid crease, and one in the lower eyelid. And he would try to remove, I think he says he removed every single fiber of orbicularis and procerus and corrugator that there was. And this, again, does certainly decrease the spasming without affecting all of the other muscles of facial animation, but there's some downsides to the procedure as well. And the downsides include the eyelid and face in general has such a great blood supply that when you remove all of these muscles, it ends up kind of being a bloody procedure because you're disrupting all of these blood vessels around the eye. Secondly, the eyelid skin is really thin, and all of the structures in the eyelid are very intricate structures, and when you disrupt this much tissue around the eyes, you can get it's a little unpredictable what the cosmetic outcome will be. And then you're also, like I said, disrupting the vasculature and the lymphatic outflow, so people could be swollen for prolonged periods of time. I think he said some of his patients were actually swollen for years after surgery. And then shortly after he described this, botulinum toxin became available, again in the early 80s. And this has allowed us to refine what is typically described as a limited myectomy as opposed to his full myectomy procedure. And this procedure works well for patients, again, who sometimes are described as toxin failures, but the toxin is usually still working, but it's not improving their quality of life enough. And I'll show you some pictures of this soon. But what you're doing is you're removing a limited amount of the squeezing muscle. You are leaving some behind. And the nice thing with this is a lot of the normal eyelid procedures that we do, either for a cosmetic patient or other patients whose vision is obscured by their eyelids, through a very similar approach, you have direct access to that muscle and you excise that muscle, but you're not making extra incisions. And so the cosmetic outcome can be a lot more predictable. You can get a significant improvement in quality of life because you're addressing other issues that are bothering the patient. But you have to understand that you will still require botulinum toxin, but it would be considered a win if we decrease the frequency of those injections, or if we if you require less total dose of injection. So, all right, here's an example. Even if she's not spasming, after toxin, her eyelids are droopy. She's got that heavy baggage around the eyelid. And you'll see that in the community and many people who don't have blepharospasm. But if you're constantly spasming, you're going to develop much heavier eyelids sooner. You get more facial age. Someone who constantly raises their brows gets more wrinkles and aging changes in the brows. If you're spasming around the eyes, you're going to get more facial aging changes sooner around the eyes. And in this case, so she would benefit from what's called a blepharoplasty, removing that heavy skin above the eyelid and raising the eyelid muscle. And while I'm there, I'm already taking the skin off, and the layer right under the skin is that squeezing muscle, so I can take that. But again, I'm not making an extra eyebrow incision. I'm not making an extra lower eyelid incision. This is her just 7 or 8 weeks after surgery. She has a dramatic improvement in her quality of life. She will continue to require botulinum toxin, but her quality of life is dramatically improved. This has been alluded to a couple times. When someone comes in for toxin failure, often it's in the setting of apraxia, or sometimes called pseudoapraxia of eyelid opening. And the etiology is a little debatable, but the thought is the orbicularis that's that squeezing muscle, is still overactive. And the muscle that lifts the eyelid, it's called the levator muscle. I always describe it as like a garage door opener muscle. The back of the eye socket's here. This is the front of the eyelid, and when the muscle squeezes, it lifts the eyelid. And that's I think it's probably normal, and when this overactive orbicularis is squeezing, the levator muscle isn't strong enough to lift the eyelids open, and the patient will constantly raise their eyebrows to see better, as opposed to classic blepharospasm when the brows are depressed. And in this case, you can try to tighten the muscle that lifts the eyelid, but it's hard to overcome the squeezing of this muscle. And you can try botulinum toxin. Sometimes that works very well too. But one procedure that seems to work well is a frontalis sling procedure, where we use a very fine string of silicone and connect the margin of the eyelid to the muscle that lifts the eyebrow. And so now when she's trying to lift her eyebrow, she doesn't have to work as hard, and that muscle can easily overcome the squeezing muscle of the eyelid. And you can, again, excise some of the extra squeezing muscle of the eyelid, the orbicularis, at the same time. And this is a procedure we have a lot of experience in, because we use a very similar procedure, that same silicone, in young children who don't have extra squeezing of their eyelid, but rather the muscle that lifts their eyelid doesn't work. So again, it's an imbalance between squeezing and lifting. But in their case, that lifting muscle is too weak. It's the kids who are born with super droopy eyelids, as well as other neurological conditions which lead to weakness of that muscle that lifts the eyelid. So again, we're addressing that imbalance and allowing her to have a much improved quality of life. So this is a nice gal. She does not have blepharospasm. She has spasms on this side of her face, and she had a tumor resected from the side of her face, and it was surrounding the facial nerve. She had some damage to the facial nerve. Unfortunately, she regained most of the function of the facial nerve, but during this recovery phase, she developed spasms on the right side of her face. And what I think is interesting, her complaints when she came to me, she was getting injections with somebody else, where she's tearing constantly from both eyes, but then on this right side, even when the botulinum toxin is working, she can't see well, and she feels like everything's heavy on that side of the face, and this eye is constantly irritated. So what I was able to do for her was remove some of that extra heavy upper eyelid skin on just the right side. It's pretty rare to do what we call a blepharoplasty on one side, but sometimes it is indicated. And then listening to her complaints, she came in for spasm-related issues, but she also had complaints on the left side. You do get aging changes on both sides of your face. I tightened both lower eyelids and tried to redrape some of this tissue here. And while I removed some of this upper eyelid skin, of course, I took out a little bit of the squeezing muscle, and she got a very nice result. And you can see her left eye is not as irritated either. So what I think is cool about this is when you have spasms on one side of the face, you get so much more aging changes, and you can see it on the same person in this picture. So a lot of the procedures that we use for everyone else can be of benefit to blepharospasm patients as well. So one of the big challenges in addressing blepharospasm is insurance companies don't consider blepharospasm an indication for eyelid surgery, and they don't consider myectomy something that they'll pay for. So this can become a big challenge. And as eyelid surgeons, we know that this is a condition that severely affects your lives, and we want to do our best to help you, and we don't think of it as a cosmetic procedure. So we have to get creative in how we talk to the insurance companies. So what we typically have to use is what insurance companies do consider an indication for eyelid surgery is the eyelids obstructing vision, and they see that as a hazard because people won't be able to see when they're driving. And it doesn't make sense in my head that they don't see blepharospasm as a hazard while you're driving and an indication for surgery. Or if the brows are so low that it's blocking the vision, they'll consider that an indication for surgery. If a patient has tearing, they'll consider that an indication for surgery. So we have to get creative, and then do those procedures that would still help the patient. And then while we're there, we can excise some of the extra squeezing muscle and hopefully help the blepharospasm even more. So in this case, she definitely does have drooping upper eyelids, and we have to send pictures and a visual field showing if we lift the eyelids that they will see better. And she was able to pass for this. And then again, I can excise some of the squeezing muscle, but then sometimes there's things that you just can't convince an insurance company to pay for. And she had, she's young, but she had some accelerated facial aging changes. A lot of people get bags under their eyes, but this bothered her too. And so we ended up having to combine this. So sometimes most of the time you can get a lot of it covered by insurance. Sometimes there will be an out-of-pocket cost. And she got a very nice result. She still would require botulinum toxin, but again, her quality of life is significantly improved by addressing these changes. And then this gal clearly does not have blepharospasm. But the reason I put this slide up is, as an oculoplastic surgeon, or a surgeon who's constantly operating around the eyelids, we really understand the anatomy of the eyelids, and this is what we do day in and day out. We get to draw on lots of experiences from different areas of our practice. So we treat patients who have skin cancer and need reconstruction of the eyelids. We treat patients who have trauma and need reconstructions of the eyelid and eye socket. We see cosmetic patients and aesthetic patients who have facial aging concerns. And then we see lots of patients with facial spasms, be it from blepharospasm or some of the other causes that have been talked about previously. And I think it's really cool. You know, it's not ideal to see a patient with blepharospasm and say they have blepharospasm, they need a myectomy. It's really cool to be able to listen to the patient, see what their complaints are, what is it that is bothering the patient, and drawing from our experiences in all these different areas, offering a procedure that will address their concerns and give them the best improvement in quality of life despite the diagnosis of blepharospasm. So in conclusion, blepharospasm is the end result of a very complex feedback loop, as has been discussed previously. Botulinum toxin is now kind of the gold standard of treatment, and there's numerous procedures available as adjuncts that we can offer to help improve the quality of life for people who have blepharospasm. There's no correct procedure for people with blepharospasm. It should be an individualized plan for what it is that bothers the patient. And then this is Dr. McClune, who is going to speak to us shortly. And the reason I put her picture up is one of the things that I find most amazing working at the University of Minnesota or any other major academic center is not only being able to provide the care that I'm capable of providing, but surrounding myself with experts who in laboratory science, with experts from the field of neurology, experts in neuro-ophthalmology, and all of the colleagues working together to provide not only the best care today, but communicating and being able to hopefully provide better treatments, a better understanding of what it is that's going on for the future. Thanks.